Good morning, ladies and gentlemen. Today I'm going to deliver the part two of the topic that I started last time, and that is the dermatosis of female genitalia. I am Professor Asher Ahmed Mashood, and you can follow me on Instagram, and please subscribe to my channel if you are attending this talk. The first disease I'm going to discuss today is Acanthosis nigricans, which is characterized by hyperpigmentation and thickening of the skin, particularly in the flexures. Most of the cases of acanthosis nigricans are associated with insulin resistance. However, it can be an underlying sign of malignancy, usually an adenocarcinoma. If it is linked to malignancy, then the onset and progression of the disease is rapid and unusual sites are involved, like eyelids, lip, and palm, which are palms are called as the tripalm. The genitals are almost always involved in acanthosis nigricans with velvety dark plaques, mainly on the labia majora that is extending to the inguinal folds. There is another entity known as the pseudo-acanthosis nigricans, which is a condition seen in obese individuals and is related to the moisture, friction, and subsequent maceration. The diagnosis is quite obvious and made clinically, and there is, of course, no need to go for a biopsy. But every patient should be monitored with blood glucose to check for type 2 diabetes, and if relevant, refer to the endocrinologist. Rapid onset of acanthosis nigricans asked for elaborate investigations to rule out any hidden malignancy. How to manage acanthosis nigricans? It is done by keratolytics, by retinoids, ointment, and laser treatment, but with limited success. Then the Dowling-Degos disease. The Dowling-Degos disease is characterized by reticulate pigmentation in the flexures. The lesions appear in third or fourth decade of life, and histopathology will show irregular elongation of the reti ridges with increased melanin at the basal layer. However, the number of melanocytes are not increased. Genetics, it's inherited as an autosomal dominant pattern. There are a number of probable variants of Dowling-Degos disease, that is localized disease, the generalized disease, the Gali-Gali disease, then reticulate acropigmentation of Kitamura, Haber disease, and symmetrical acropigmentation of Dohi. Management, there is no successful treatment. Many creams are tried, including topical steroids, azelaic acid, retinoids, and depigmenting agents like hydroquinone, but none is found to be effective. If there is itching, topical steroids can be prescribed. Erbium YAG laser may be used to treat the rash between the breast, but it is of course not the treatment of choice. Vulval pain. Vulval pain, also known as the Vulvodynia, is defined as the vulval discomfort, most often described as the burning pain occurring in the absence of relevant visible findings. So this is must, that vulvodynia is labeled only when there is a vulval pain with no associated disease. If any active dermatosis is found, then this symptom is accounted for that syndrome, and then it's not called as the vulvodynia. But it is possible that a dermatosis may heal, but the pain persists. There are several causes of vulval pain. The specific disorders that would lead to this symptom include infections like recurrent candidiasis and herpes, Then inflammatory conditions like lichen sclerosis at atrophicans, lichen planus, and immunobullous diseases. Neoplastic conditions like Paget's disease or squamous cell carcinoma. Neurological conditions like post-herpetic neuralgia, nerve compression, injury, or neuroma. Then traumas like female genital cutting and obstetric trauma. Iatrogenic in post-operative chemotherapy or radiation-induced damage. Then sometimes hormonal deficiencies like genitourinary syndrome of menopause. The vulvodynia, which is not related to some specific cause, can be localized like vestibulodynia or clitorodynia, or generalized or mixed. It may be provoked, for example, provoked by insertion of the penis or contact. It can be primary or secondary. Then there is temporal pattern to this vulvodynia. That is, it may be intermittent, it can be persistent, constant, immediate after the provocation or delayed. It's important to remember that a form of dysthesias, more accurately labeled as post-inflammatory vulval hyperesthesia, is a problem following the inflammatory conditions of vulva, particularly those involving the vestibule, and is most frequently seen in erosive lichen planus. Pathophysiology of vulvodynia is unknown, but existence of complex regional pain syndrome is well recognized. Depression is a common feature of chronic pain, but it is difficult to determine if it is a primary cause or a secondary effect to vulvodynia. Clinical features. In provoked vulvodynia, the classical history is that of pain with penetration at intercourse. And this also occurs when tampons are used or specular examination is performed. There will be a touch-provoked tenderness over the vestibule when the pressure is applied with a cotton-tipped swab. That is the touch test. And this is maximum at 5 o'clock and 7 o'clock position. In the generalized form, pain may vary in intensity and patients may complain of shooting pain to the pelvis, thigh, and anal region. Dyspareunia is not generally a feature. The vulva looks completely normal on examination, and in some patients, pain is localized to clitoris, and this is then termed as the clitorodynia. Differential diagnosis. Exclude the dermatoses, infections, and malignancy that can cause pain. The mechanical hymenal tear and vestibular fissures can cause pain, should be picked up on examination. And sometimes it's helpful to examine the patient immediately after intercourse to assess these issues. Pudendal neuralgia is confused with generalized vulvodynia, but here the pain is alleviated by standing. Disease course and prognosis. There is a spontaneous resolution may occur, but unusual. As with all chronic pain problems, the patients show a steady but slow response to treatment, and sometimes combined therapies are required and psychotherapy is sometimes needed. The first line is lidocaine 5% ointment applied regularly to the maximum point of tenderness. This is particularly helpful for provoked pain. Second line is low-dose tricycline amitriptyline 10 mg at night, increasing by 10 mg increments to maximum 200 mg daily. Newer agents are also used that include pregabalin, gabapentin, and duloxetine. Physiotherapy is particularly useful for associated vaginismus. Third line, refer to a pain clinic or psychosexual counseling. Vestibulectomy is not advocated as a routine procedure because there is less chances of anatomical defect, and it's more of a psychological condition. Vulvo-vaginal adenosis. This condition is due to presence of metaplastic cervical or endometrial epithelium. Pathogenesis is unknown, but postulated that it develops from remnant tissue of mesonephric origin. Prolonged use of oral contraceptive pills and trauma can predispose to adenosis. The lesions appear red and friable, and it is associated with vaginal adenocarcinoma. Histology of the lesion will show a mucus or endometrial glands in the skin. Laser treatment is considered helpful and useful. Necrolytic migratory erythema. This dermatosis is usually seen in patients with glucagonoma syndrome. Etiology is unknown, even though there is a very strong link to high level of glucagon in the glucagonoma syndrome. The eruption is not reproduced by injection of glucagon and does not occur in other conditions where increased level of glucagon are found, such as diabetes and renal failure. Moisture, friction, and trauma precipitate the fresh lesions. Necrolytic migratory erythema, the lesions present with itching, with central healing and active border. That is why it is classified as annular erythema, but the border contains the vesiculobullous lesions, giving an annular morphology at the intertriginous areas. The lesions on vulva, perineum, and perianal skin may extend to thigh and lower abdomen. The central face and limbs are rarely involved. Later on, there is extensive eroded erythema, crusting and desquamation, serpiginous edge that spreads centrifugally, giving rise to characteristic annular configuration, as you can see in this picture. Histology. Histology will show parakeratosis, and the keratinocytes, as you can see in the picture, are vacuolated and pale. And there is intraepidermal clefting. Subcorneal pustules may be seen. You can see subcorneal pustule and intracorneal edema. Differential diagnosis. Similar picture is seen with zinc and protein deficiency. So acrodermatitis and pellagra have similar histological features. Eruption may relapse and remit, and post-inflammatory hyperpigmentation can last for a few weeks. The eruption resolves rapidly after surgery or medical treatment. Investigation. Skin biopsy with the features described above. Endocrinological and imaging investigations are required to confirm any associated glucagonoma. The management is with surgical resection of the tumor, chemotherapy, which include streptozotocin and 5-fluorouracil. Then somatostatin analogs like octreotides, and glucagon receptor antagonists, that is Ozempic and Saxenda, liraglutide and semaglutide. Topical steroids are helpful for the cutaneous manifestations. Genital papular acantholytic dyskeratosis. This is characterized by presence of multiple papules or less frequently a single papule or plaque-like lesions on the genital skin. Middle-aged females are commonly affected, and the main symptom is that of pruritus. It presents as multiple small papules up to few millimeter in size, appear in the inguinal folds and extend to thigh and perineum. They may coalesce to form nodules or small plaques. You can see these multiple small papules coalescing into plaque. If we do the histology is that of any other acantholytic dermatosis like Derriere or Hailey-Hailey disease. The histological similarities are with Derriere and Hele, but there is no family history or evidence of the disease in other sites. Laser treatment is reported to be useful in those who are unresponsive to topical steroids or retinoids. Then human papillomavirus infection. Human papillomavirus is a small DNA virus, and the type that most commonly affect the genital sites is type 6, 11, 16, and 18. The most commonest of the sexually transmitted infection, and up to 85% of people will be infected with at least one of the type of human papillomavirus in lifetime. Warts are most commonly seen in younger age group after sexual activity starts. And if occurs in children, it should raise the possibility of sexual abuse. Immunosuppressed patients often have more florid infection with lesions that are difficult to treat. They are also at greater risk of developing human papillomavirus-associated anogenital cancers. There is an increased risk of acquiring genital warts with higher number of sexual partners. So more active you are sexually, the more chances of acquiring these warts, and the presence of other sexually transmitted infections and history of smoking. Histopathology of condylomata acuminata, there is parakeratosis and vacuolation of superficial keratinocytes, mainly in the granular layer. So along with these vacuolation, there is intranuclear eosinophilic inclusion, which are actually the human papillomavirus itself. The warty lesions are known as condylomata acuminata, as you can see in the picture. Extensive vegetating mass can cover the vulva and perianal area, particularly in diabetes, pregnancy, and immunocompromised patients. Complications and comorbidities. The human papillomavirus 16 and 18, and sometimes 32, 33, are associated with anogenital intraepithelial neoplasia and SCC. The warts may resolve spontaneously, but may persist and be resistant, especially in immunosuppressed patients. These are the patients in which these warts turn into malignancy. Management is by podophyllin, by cryotherapy, by topical imiquimod, and destructive treatments. Imiquimod is used with care as it induces inflammatory response in patients who have a latent or active dermatitis. In pregnancy, only cryotherapy and destructive techniques like cautery and hyphocation is safe. Prophylactic vaccination prior to exposure is now available for human papillomavirus type 6, 11, 16, and 18, and is shown to reduce the incidence of wart and genital intraepithelial neoplasias. Benign tumors, the mucous cyst or mucinous cyst. This occurs at site if there is an obstruction of duct of minor vestibular gland. Occur in adult women and rarely in adolescents. Cysts are of urogenital sinus origin and are lined by mucous epithelium. You can see this lining, the mucous epithelium, ciliated mucous epithelium. The lesion present as single or multiple lesions in the vestibule, and simple excision is curative. Bartholian cyst is common and arise as a result of obstruction of the main duct of Bartholian gland. These are most common in women of childbearing age. Cyst is lined with transitional epithelium, which exhibit squamous metaplasia. Simple cysts are asymptomatic and patient may simply notice a lump and present as swelling 1 to 3 centimeter in size in lower third of the inner labium major. Benign and malignant tumor can present in the similar way. If cysts become infected, then this abscess lead to painful swelling. The treatment is, of course, enucleation of the cyst, but if incompletely removed, it can recur. Papillary hyderadenoma. It's a sweat gland adenoma with apocrine differentiation, occur almost exclusively in anogenital region of middle-aged white women. Well-documented nodule is seen and composed of papillary processes that extend into the cystic space, PA stain positive, the cytoplasmic granules. Lesions are often asymptomatic but can be painful. Lesions are 1 to 2 centimeter nodule, most commonly occurring on labia majora and interlabial sulcus, lateral surface of labial minora and perineal region. Although it is usually single, but multiple lesions may develop. When they are multiple, all lesions tend to develop on one side of vulva. So malignant changes within papillary hyderadenoma are reported, producing apocrine carcinoma and adenosquamous carcinoma. And as far as the treatment is concerned, simple excision is curative. Cutaneous endometriosis. Endometrial deposits are seen on vulva, which is rare finding. Lesions are painful, and patient report variation in size with menstrual cycle. They may bleed at the same time as menstruation. The lesions present as a small bluish nodule on perineum and episiotomy scar and umbilicus. Surgical excision is curative. Then vulval melanosis, which is characterized by hyperpigmented lesions in absence of previous cause, and there is no increase in melanocytes. Condition looks like freckle on the skin. More commonly in young women, there is basal hyperpigmentation, as you can see in this picture, but there is no increase in number of melanocytes. Pigmentary incontinence, continence, and pigment-laden macrophages are seen in upper dermis. Melanosis is asymptomatic and usually an incidental finding, as you can see in this picture. Lesions are usually multifocal. Single lesion would be termed as the genital melanocytic macule, which is often irregular and asymmetric. The color may vary, and they are more common on inner labia minora. Vagina and cervix may also be involved. The main differential diagnosis is from genital antigens, but in genital antigens, there will be increased number of melanocytes. This clinical appearance, because of variable color, may mimic with melanoma, and hence biopsy is always recommended. Disease course and prognosis, dermoscopy is helpful, but when there is uncertainty, vulval biopsy is performed. It is accepted that vulval melanosis is a benign condition, but long-term follow-up is required. Then atypical genital nevi. All type of nevi can occur on the genital skin, but they may show atypical and concerning features. And it is important to be aware of this entity to avoid the aggressive treatment. The presence of vulval nevi is estimated as 2.3% in one series, most commonly seen in young women, but children and teenagers are affected as well. Histological features are difficult to interpret. They may be asymmetrical with junctional component. The nevoid cells are atypical with cytological atypia visible both at the junction and in the dermis, and dermal mitosis are evident. So the most common site is inner aspect of labia majora and minora and clitoris. Melanoma is the closest differential, but melanoma is seen in elderly, while atypical nevus is seen in younger patients. Complete excision is recommended. I am going to discuss melanomas later. First, we'll discuss the pre-malignant conditions. In pre-malignant conditions, the first condition to be discussed is high-grade squamous intraepithelial lesions, which are abbreviated as HSIL, HISL. A related condition is vulval intraepithelial neoplasia, or VIN. Then other related conditions are Bowen's disease, bovenoid papulosis, carcinoma in situ, and carcinoma simplex. The high-grade squamous intraepithelial lesion are non-invasive pre-malignant disease that progress to vulval squamous cell carcinoma. This condition is human papilloma virus related condition. The other pre-malignant change is that of differentiated vulval intraepithelial neoplasia, which occur usually in a background of lichen sclerosis. In 2004, the International Society for a Study of Vulvo-vaginal Diseases proposed replacing the three-tier grading system with two types of vulval intraepithelial neoplasias, undifferentiated and differentiated. The differentiated vulval intraepithelial neoplasia is the term reserved for severe atypia, confined to basal layer, most often seen on background of chronic scarring dermatoses like LSA. The classification does not include Paget's disease or melanoma in situ. The differentiated vulval intraepithelial neoplasia remain a precursor of invasive malignancy on background of inflammatory disease. This table is very important because this table highlights the difference between the two similar and related conditions. The first is HSIL, or high-grade squamous intraepithelial lesion, and the second condition is the differentiated vulval intraepithelial neoplasia. As far as the age is concerned, HSIL occur in younger women, while differentiated VIN occur in older women. HSIL is associated with type 16 and 18 human papilloma virus, while cervical intraepithelial neoplasia is related to lichen sclerosis. Lesions. HSIL is multifocal, while VIN is unifocal. The risk factor of HSIL is smoking and immunosuppression, while there is no risk factor of VIN. Progression to SCC, it is low risk, 9% with 1 to 8 years in HSIL, while it is high risk in vulval intraepithelial neoplasia. So the first HSIL respond to medical treatment. However, surgical treatment is prudent in all VIN. Pathology. There is 2/3 of full thickness loss of cellular stratification throughout the epidermis with large hypochromatic cells, dyskeratosis, multinucleated cell, and mitotic figures. The differentiated VIN histology is subtle, basal layers with abnormal keratinocytes as differentiated as mentioned above. However, these changes occur in the background of original disease like LS, or LSA, or LP. Clinical features. The main symptom is pruritus, but some patients are asymptomatic. The lesions of HSIL are solitary and multiple. I have mentioned that it can be multifocal, and lesions resemble like a viral wart, plaque that may be shiny and smooth, skin-colored or red or white, pigmented resembling seborrheic keratosis. Less commonly, lesions are large and polypoid, particularly in the perianal region. You can see the different kind of lesions of HSIL. Here, the lesions are in the form of white plaques, and here it is in form of hyperpigmented plaque. So you can see the cellular atypia at the basal and suprabasal layers. And if we do keratin stains like P16, it strongly stains this tumor. And P53 is also focally positive. Then differentiated VIN will appear as subtle red hyperkeratotic irregular lesions. You can see these lesions on background of LSA. You can see this LSA. This is after excision. Complication. HSIL are caused by failure of host to mount effective immune response against human papillomavirus. So immunocompromised have a high risk of this problem. This is associated with multicentric disease, with lesions of intraepithelial neoplasia involving the cervix, vagina, and perianal skin. Risk of progression to invasive disease is about 10%. Patients with differentiated VIN are more likely to develop an invasive carcinoma. However, it's a rare diagnosis prior to the development of SCC. Management. In case of solitary lesion, simple excision is curative. Surgical excision is always recommended in differentiated VIN. In women with extensive HSIL, require regular long-term follow-up and biopsies of suspicious areas, and thick and polypoid lesions must be excised. Cryotherapy is not effective. However, 5-fluorouracil is used successfully in labia minora, vestibule, and clitoral areas. Laser vaporization has high recurrence. Imiquimod is proved to be effective in treatment of multifocal disease and younger patients and recurrent disease after surgical excision. The development of human papillomavirus vaccine, which are licensed in Europe to prevent as a preventive management since 2006, have already had an impact on decreasing the incidence of HSIL and will continue to do so. So this vaccine is must for all the sexually active individuals. Then few malignant tumors. The first is the squamous cell carcinoma, which is the most common malignancy occurring in female genitalia and account for 90% of all vulval malignancies. Incidence is 1 to 2 per 100,000. And there appear to be two types of vulval SCCs. The first and the largest group occurs in elderly women on a background of chronic dermatoses like LSA or lichen planus. The second type is the one which occurs in 40% of the cases in younger women and associated with intraepithelial neoplasias that are associated with human papillomavirus. So you can see this nodular lesions, and on histology there is carcinoma in situ with atypia involving the whole thickness of epidermis. In older age, the tumors are usually well to moderately differentiated and keratinized, whereas younger human papillomavirus associated group, they are poorly differentiated and often non-keratinizing. You can see the nest of atypical squamoid cells in the dermis or submucosal tissue. Common symptoms are soreness and pruritus. Bleeding occur if tumor is ulcerated. Sites are labia minora, labia majora, clitoris, perineal body, and foci. Patient may present because of the presence of nodule or plaque. Classification of severity. There is combined TNM classification and FIGO, Federation of Gynae and Obstetrics staging system, which is based on the clinical histology examination and histological criteria. The overall 5-year survival is approximately 75%, which rises to 90% or greater in those with no nodal metastasis. The main reason of the treatment failure is inability to control lymphatic and distant metastasis, while the lymphatic spread is the most common factor. Surgery remains the primary treatment modality for locally resectable vulval cancers, and the surgical excision is tailored to the size and site of the tumor. These patients are managed in a multidisciplinary setting with gynecology oncologists, plastic surgeons, clinical and medical oncologists. Central lesions, which are placed in the clitoris, urethra, and vagina fossa and perianal area, will have bilateral lymphatic spread, and important in this case is that the inguinofemoral nodes of both sides are excised. Radiotherapy is used as an adjuvant treatment in patients with positive nodes and in those with inoperable tumors. It is sometimes used as a primary treatment together with chemotherapy in tumors of anus and urethra to reduce their size before surgery. Then the verrucous carcinoma, also known as the Buschke-Lowenstein tumor. These kind of tumors occur in older women. Verrucous carcinoma occur on background of LSA. Histological changes comprises of epidermal acanthosis with large bulbous reti ridges, very little cellular atypia, no dermal invasion, and few mitosis, which are confined to the basal layer. Lymph node and distant metastases occur very rarely, and portion of cases harbor human papillomavirus. Clinically, the lesions appear as warty plaque or cauliflower-like tumor that can ulcerate and become large. Multiple biopsies are often required for confirmed diagnosis. Treatment is wide local excision. Oral retinoids are helpful. Then extramammary Paget's disease. The primary extramammary Paget's disease, EMPD, is an intraepithelial adenocarcinoma arising in the epidermis or skin appendages. Secondary extramammary Paget's disease is epidermal involvement from an internal neoplasia, either by direct extension or metastasis. The association with malignancy is 30% and generally affect women over 50 years. So there are two kinds of extramammary Paget's disease, the primary and secondary. Primary is primary intraepithelial neoplasms, intraepithelial neoplasms with invasion, manifestation of primary adenocarcinoma of skin appendages or subcutaneous glands of vulva. The secondary is secondary to anal or rectal carcinoma or secondary to urothelial neoplasia. Secondary to adenocarcinoma are related to other sites. Pathology. There is frequently epidermal hyperplasia. Epidermis is infiltrated by pale staining Paget cells, which are PS positive and diastase resistant, stained with Elsham blue and with keratin dyes like CK7. Lesions are typically moist, red plaques for a long time with itching and burning sensation. Disease course and prognosis. Recurrence is common, and with all currently available treatment, regular monitoring and evaluation of invasion is important. Prognosis for primary intraepithelial disease is excellent, while for invasive disease, 5-year survival is around 72%. Management. Primary extramammary Paget disease, excision of the visible disease, then patients should be regularly monitored with topical steroids and for troublesome pruritus. Recurrence rate of over 40% after Mohs micrographic surgery. The disease can recur after 27%. Medical treatment include 5-fluorouracil, bleomycin, and oral retinoids. Recurrence rate are higher if carbon dioxide laser or radiotherapy is used as the primary treatment. Photodynamic therapy is of some benefit. It is of interest that 5% imiquimod is useful in widespread disease and in recurrence after surgery. Overexpression of HER2 new protein is found in 30%, and there are reports of use of trastuzumab as a target therapy has shown a promising result. In secondary disease, treatment is direct predominantly to the main adenocarcinoma. Then basal cell carcinoma accounts for 2 to 5% of vulval malignancy. These tumors generally occur in elderly but may be seen in younger women. Vulval BCC present as eroded plaque that may be pigmented. Less commonly, the tumor may form a nodule or an ulcer, and frequently over labia majora or mons pubis. A wide local excision or margin-controlled surgery with Mohs micrographic surgery in large or ill-defined lesions is the treatment of choice. Inadequate excision accounts for recurrence rate, and vulval BCC is reported to metastasize to regional lymph nodes. Then vulval melanoma is a rare condition and account for 2 to 10% of vulval malignancies. Most often affected is 6 to 7 decade. Mutation in KIT pathway are more common in vulval melanoma than other mucosal lesions. Vulval melanoma is often asymptomatic until it ulcerates and become nodular and bleeds. Labia majora and clitoris are the most common sites involved. Clinical features are similar to melanoma elsewhere. 5-year survival rate is 11.4% for female genital tract melanoma, and diagnosis is made histological. Management. The primary management is wide local excision with an input from the multidisciplinary team. Adjuvant treatment and immunotherapy is needed after surgery and in those patients who are inoperable. This brings me to end of my talk. Thank you very much for patient listening, and you can follow me on Instagram by this QR code. Thank you very much and have a very good day.